Hello, everyone. You're all welcome to this webinar on HIV, STD, and hepatitis in Idaho, hosted by the Idaho Collaborative for Infectious Disease Prevention, ICIDP. As we all know, just like the entire nation, the rates of and absolute numbers of the cases of HIV, chlamydia, and syphilis and gonorrhea have risen steadily over the last 2 decades. ICIDP was born in June 2022 from a partnership between the Idaho Department of Health and Welfare and the Idaho State University. So the vision is to build and maintain a compassionate workforce in Idaho with the capacity to effectively address prevention, harm reduction, and care for HIV, STIs, viral hepatitis, and other infectious diseases, especially in underserved communities. So we hope to achieve this by building interprofessional partnerships and enhancing workforce development in infectious diseases through education, training opportunities, and research. So ICIDP and this webinar are made possible by funding from the CDC through the Idaho Department of Health and Welfare. We're excited that you have all accepted our invitation to be part of today's training event, which was designed to bring together clinicians, public health practitioners, people living with HIV and hepatitis, community-based organizations, and academics, health educators, community members, and other stakeholders involved with the management, prevention, and control of HIV, STDs, and viral hepatitis in Idaho. We would love to hear everyone introduce themselves, but the size of this gathering will not permit that. So we ask that you kindly introduce yourself by providing your name, role, and organization in the web chats, webinar chat. So we have distinguished speakers and panelists today. Michelle Van Handel from the CDC, Dr. Sky Blue, and Dr. Stacy Lamers from Full Circle Health. I will speak more about and talk more about these speakers before each of them takes the stage. We also have the faculty members of ISU who serve on the leadership team of ICIDP, and Christine van der Grand and David Hashi. So before we dive into the business for today, I feel that you respond to the poll questions that will be displayed during the webinar and to foster engagement and interaction. And also remember to use the Q&A function of the webinar after each presentation if you need to. And our panelists will do their best to respond to your questions. So let's start with some polls so we can all know the composition of the audience we have here better and have an idea of who is in the room. Okay, so there we go. Community-based organizations, 7%, community health centers, 14%. Majority of people here are from local health departments. Thank you very much. The first speaker for today is Michelle Van Handel. He's the Associate Director for the Program and Performance Improvement Office at CDC's National Center for HIV, viral hepatitis, STD, and TB prevention. And in this role, Michelle works with colleagues across the CDC to evaluate and enhance the efficiency, outcomes, and impact of the center's programs, policies, and activities. She has authored 40 peer-reviewed manuscripts evaluating HIV, STI, and viral hepatitis health outcomes, estimating population size and costs related to pre-exposure prophylaxis, and assessing communities at risk for HIV and hepatitis C virus outbreaks. Michelle earned a bachelor's degree in medical microbiology and immunology from the University of Wisconsin-Madison, and a master of public health from Drexel University School of Public Health in Philadelphia. So it's a huge honor to have her here to shed light on the value of a syndemic approach to address HIV, viral hepatitis, STI, and TB, and give some words of encouragement too from the CDC. Over to you, Michelle.
Great. Thank you so much, Nnamdi. Good morning, everyone. Thank you for the opportunity to join you today for your statewide collaborative meeting. This is such an exciting opportunity to bring together all of the amazing people I saw in the on the poll. So clinicians, public health practitioners, people living with HIV, STIs, and hepatitis, community-based organizations, academics, and other partners involved with preventing and caring for people with these infections in Idaho. Given this amazing cross-cutting group, I'd like to talk about the value of a syndemic approach to address HIV, hepatitis, STIs, and TB. Perhaps first, I think we have at least one poll question maybe we can post just to get our thoughts going on what we think about when we think about syndemic approaches and what those challenges or facilitators may be. I'll defer to you on the length of time. Great. Excellent. So we're seeing about 80% of folks are already doing case investigation and outbreak response, 70% are doing health communications, and then others are also doing venue-based multi-disease prevention, diagnosis, and linkage, as well as multi-pathogen diagnostic testing. And then barriers, oops, I've missed it, but I think I saw funding, which I'm not too surprised, that's the number one, and then not a priority for the organization. So understand both of those and hope we can talk a little bit more about what those strategies are and the biggest barriers you're facing. Next slide. Great. So first, a bit of background. Within our center, we have set a vision of a future free of HIV, viral hepatitis, STIs, and TB, and aim to achieve this vision by preventing infections, morbidity and mortality, health inequities, and stigma associated with HIV, viral hepatitis, STIs, and TB. I'll try not to repeat all of them 10 times. Our core values situate us to achieve specific goals towards this mission and include excellence, equity, diversity, inclusion, accessibility, and belonging, as well as integrity and transparency. Next slide. Our overarching goals are to reduce incidence, reduce morbidity and mortality, and reduce disparities and promote health equity, as well as achieve organizational excellence. Next slide. When we look at the epidemiology of these infections, we see sort of mixed trends with regards to the US. So HIV incidence is declining while HIV prevalence is actually increasing. Our prevention efforts have saved tens of billions of dollars, leading to more people living with HIV who are living longer and healthier lives. Next. However, while HIV affects everyone, it is not equal. Prevalence of HIV is over 100 times higher in men who have sex with men and transgender women than heterosexual men and women. In addition, HIV incidence is 8 times higher among African American people and 3 times higher among Hispanic and Latinx people than white people. Next. In rural areas in the US, we also see disparities, with rural residents less likely to get tested for HIV and more likely to have progressed disease when diagnosed. For people with HIV in rural communities, 46% are retained in care and 50% are virally suppressed, both of which are lower than the national average. Some barriers to care include great distances, great distances to services and limited transportation, limited HIV providers and support services, cost of care, stigma and discrimination, confidentiality concerns, and limited access to substance use treatment and harm reduction services. While HIV incidence is decreasing, other STIs have been increasing since 2014. Based on 2022 data, there were 1.6 million cases of chlamydia, 650,000 cases of gonorrhea, 207,000 cases of syphilis, and 3,755 cases of syphilis among newborns. As with HIV, some groups are more affected, including young people aged 15 to 24 years, gay and bisexual men, pregnant people, and racial and ethnic minority groups. Just to focus a little bit for a minute on congenital syphilis. So congenital syphilis has surged to more than a 31-year high in 2022. And some key missed opportunities for preventing congenital syphilis include timely syphilis diagnosis, but no adequate maternal treatment and no timely syphilis testing. Next. Disparities in rural areas exist with regards to STIs as well as HIV, with rural females and males having higher rates of negative health outcomes from STIs, such as HPV-associated cancers. Disparities in behaviors that increase risk are also observed. Compared to students attending urban schools, students attending rural schools were more likely to be currently sexually active and have 4 or more lifetime sexual partners. Some factors influencing STIs in rural areas include access to quality STI prevention and control services, stigma, poverty, and attitudes and community norms regarding sexual health. Next. For viral hepatitis, new 2022 data signal progress in reducing acute viral hepatitis, with substantial decreases in hepatitis A following the outbreaks that were experienced in many states, and plateauing and potential decreases in hepatitis B and hepatitis C. Next. However, we do need to better understand if this is occurring consistently across the US, as we've seen hepatitis C rates about twice as high in rural areas as urban areas in the past. And some factors that affect hepatitis rates include limited access to resources, lower income and education levels, under and uninsured status, having more dispersed healthcare, longer travel times, less likely to access healthcare, as well as limited access to medication for opioid use disorder, harm reduction services, overdose prevention, as well as stigma. And lastly, I know not a major focus for today, or at least I believe not, but just to note briefly, during 2023, a total of 9,615 TB cases were provisionally reported, representing a 16% increase compared with 2022 data. And when we're looking across states, we see a wide range of rates from 0.2 to 44.7 per 100,000. And while we may be seeing, that's bright pink, while we may be seeing varying progress in reducing these infections, we have the tools to achieve our goals and have identified different prevention focus areas. For HIV, we're really focused on treatment as prevention. We know treatment saves lives and prevents transmission. We're also focused on HIV pro-exposure prophylaxis uptake, data to care and data to care RX, where we're using surveillance data or prescription data to monitor and relink people who may have fallen out of care, and then cluster detection and response. For viral hepatitis, we're focused on increasing diagnosis and treatment, increasing vaccination for hepatitis A and hepatitis B, reducing the spread associated with drug use, and rapidly detecting and responding to outbreaks. For STIs, we're really focused on doxy-PEP implementation, uptake, and guidelines, drug-resistant gonorrhea detection and prevention, and timely testing and adequate treatment for all STIs. And then for TB, we're focused on increasing latent TB infection diagnosis, electronic direct observed therapy, and outbreak detection and control. Next. And what you may notice and likely already experience in your work is that there's a lot of overlap in both the populations, drivers, and prevention tools across these infections. We view these infections as being embedded within interrelated syndemics. A syndemic is when 2 or more diseases or health conditions cluster within a population, and the social, structural, and epidemiologic factors create conditions for the clustering such that it results in adverse disease interactions, increasing the health burden of the affected population. Simply stated, a syndemic is population-level clustering of both social and health problems. And so we've been really working to sort of develop an approach at multiple levels, both internal and then how we're working with partners externally. And one key aspect of that is that with the overlapping drivers of these syndemics or epidemics, it also means that there is also a potential positive opportunity to more fully address the common drivers of these syndemics. We've been working to articulate what this more holistic approach to individual and population health looks like for us. So at the top level, we looked across our effective interventions, got input from others, and identified 5 high-impact strategies that our syndemic approach prioritizes, including venue-based multi-disease prevention, diagnosis, and linkage services to address more than one infection and link to care, prevention, and essential services. This is really a one-stop shopping of sorts for populations who urgently need healthcare. The second strategy is to develop and expand multi-pathogen diagnostic testing and other technological solutions, so testing for multiple infections can happen at one time. So this could be like the chlamydia and gonorrhea NAT test, but it could also be things like clinical decision support tools that do a best practice alert or do automatic lab orders if someone is within an age group that would be recommended for one-time screening. The third strategy is case investigation and outbreak response. You all know this very well based on the poll responses, of course. And that really is aiming to address multiple infections through an integrated response strategy. This could include cross-training for DIS, as well as thinking about how do we bring services for one outbreak that includes multiple infections. The fourth is a health communications strategy that uses integrated disease prevention communication messages, products, and campaigns. So really thinking about it from a more comprehensive sexual health level, but also a population focus. How are we communicating the potential services available or risks for multiple infections to populations who might be disproportionately affected by more than one infection? And the fifth is integrated and aligned data systems that provide the structure to collect, report, and monitor multiple health outcomes so that we have a better understanding of what's happening at the national, state, and local levels with regards to these syndemics. Next. We also thought about how to build the foundation of this work and are focusing on people, place, policy, and science. We must reach the people most affected by these syndemics. We must identify the geographic locations and venues with higher burden and where these people and populations are already living and working. Anywhere populations intersect with public service programs can be a critical intervention point. We also need to support effective policy interventions that address social and structural factors. And so when I think about policy, I'm thinking about all levels, really thinking about how we can set up our organizational policies to facilitate, let's say, opt-out screening in our clinical health settings. And we need to conduct research to advance syndemic approaches. So I thought we could spend just a couple slides going over a few examples of how these priority syndemic strategies interact with the foundational pillars. So getting started, let's say you want to expand venue-based multi-disease prevention, diagnosis, and linkage services. This is a broad category that includes community-based testing programs, opt-out screening programs in clinical settings, harm reduction, certain services programs, HIV PrEP, and vaccination. So we've already talked about like how funding is a barrier. So we can't do everything. And so to better understand what more specifically is needed from a community, start by understanding the epidemic and the challenges populations affected face. Then identify where the affected populations already go for services and develop collaborations to support a more whole community approach. And last, work to build the partnerships with community to identify expanded services needed, such as routine infectious disease screening, naloxone distribution, transportation, and housing, and how these partnerships can support linking people to needed services. Some example service sites we found effective include integrated screening in emergency departments, community health clinics, harm reduction and syringe services programs, telehealth and self-testing, STI clinics, and community-based organizations. And so the next couple slides, I'm going to go over the first three. That's okay, go ahead. There we go. So integrated screening has been implemented in a variety of settings. One example is from the Veterans Administration. When they implemented an opt-out HIV screening program using a clinical reminder, screening rates more than doubled in just 2 years. In another example, in an emergency department, an EHR generated laboratory orders that identified people recommended for testing based on year of birth or age. That led to a 142% increase in hepatitis C virus testing. And when they added on a component to identify a country of birth for which hepatitis B screening is recommended, Hep B testing increased by 91%. Another effective way to bring services to those with and at risk for these infections is through harm reduction and syringe services programs. Harm reduction is a movement to meet people where they're at without judgment to provide life-saving services. The aims are to reduce the harms associated with substance use, offer non-judgmental services and support, and accept that not everyone is interested in or capable of stopping their substance use at a given time. Harm reduction strategies include a wide range, and that does include SSPs, but also naloxone distribution, medication for opioid use disorder, such as buprenorphine and methadone, fentanyl test strips, and over-the-counter syringe sales. These strategies could be a part of community-based organizations or local health department programs, and they can also be integrated into substance use treatment and other healthcare settings overall. No worries, go ahead. Nearly 30 years of research conducted by scientists at CDC and elsewhere has shown SSPs to be safe, highly effective, and cost-effective at reducing bloodborne infections among people who inject drugs. Access to sterile syringes and safe disposal of used injection equipment are core services of all SSPs. Access to sterile injection equipment can help prevent bloodborne infections, skin infections, and endocarditis. Other services include vaccination, testing, and linkage to infectious disease care, as well as provision or linkage to substance use disorder treatment. And multiple studies pulled together have estimated that SSPs reduce the risk of HIV and hepatitis C transmission by 50%. And when that's combined with medication for opioid use disorder, it reduces the risk of these infections by nearly 3/4. Oops. Access to, excuse me. Additionally, drug use does not increase when SSPs enter communities. SSPs protect the public and first responders by facilitating and the safe disposal of used needles and syringes. And persons engaged with an SSP are 5 times as likely to enter treatment for substance use disorder than people not engaged with SSPs. So the last example I want to highlight to think about how to implement these strategies in the places and for the people most in need is through telehealth and self-testing. Telehealth can be key for delivery of care and prevention in rural communities by connecting people to providers and removing travel and stigma-related delays in care. Self-testing is also another way to bring services to people, to where people are. An HIV self-test is an antibody test that can be used at home or in a private location and can get your result in 20 minutes. A home specimen collection kit can be used to test for HIV and STIs, and if it is ordered by a physician, it is often covered by insurance plans. And then I just want to point out that the sources at the bottom have some additional resources for the self-test kits in particular. And so to wrap up, our center's national assessment of these syndemics is important, but syndemics are local and require local understanding and action. Local public health professionals are uniquely situated to respond to evolving needs in their communities. By assessing local data, public health professionals can better understand the populations disproportionately affected and invest resources in the venues serving those in need in the geographic areas with the greatest burden. A third action to consider is leveraging policy as a public health tool by assessing the policies in the areas you serve and exploring how policies can address the social and structural factors that drive your local syndemics. As I mentioned, this can be at all levels, thinking about opt-out screening policies or how we're supporting training within our organizations. All of our actions must embed equity principles that include supporting trainings to improve cultural responsiveness and appropriateness in how we plan and deliver services. And last but certainly not least, we must truly engage the community so that they are actively informing and building these systems in partnership. I am so looking forward to the next presentations and grateful for the opportunity to learn more about the amazing work you all are doing and leading in Idaho. I think we have time for questions now, but I'm also able to stay on throughout the session.
Yes, thank you very much. And Namdi, if you can just pull the slides down for just a minute while we walk through the Q&A, that would be great. Just stop sharing so that we can, there we go. So we can see Michelle full screen. So first of all, again, thank you very much. That's an absolutely wonderful presentation. And I do want to remind all the attendees out there that please feel free to chime into the Q&A with questions. I do recognize many names out there, and I'm happy to call on people for specific questions. That's the professor in me, so I'm not hesitant to reach out to Ian. I know Ian always has questions, and Jeff. So, but I do have a few questions to start with for you. Just going through some of the overview with trends in HIV and STIs. What are some of the national strategies that you're seeing being employed to target the higher incidence areas of HIV? Certainly, Idaho is one of the lower incidence states, and with that, we are generally under-resourced in a lot of areas. But areas in the South and the Southeast, can you describe some strategies that are really being used there?
Sure, of course. Thank you. Great question. So with regards to HIV in particular, you may be familiar with the Ending the HIV Epidemic Initiative. Sometimes we get in our bubble, so I don't want to assume everyone knows it. But that one really, this initiative has really focused on a phase 1 set of areas that are the 50 counties that have the highest HIV prevalence rate in the US, as well as some of the more rural states that ended up being in the South with higher rates throughout the states. And so through this initiative, we are actually wrapping up a cooperative agreement that really focused on directing resources to those areas and really outlining sort of our EHE pillars to diagnose, prevent, respond, and treat, but also really recognizing that local communities know what's best for them and building in flexibility to allow for intervention to be implemented that really work for their communities. Another way that we do this is through actually each of our sort of main funding agreements with all states is that we do distribute funds based on burden. And I know that this can be a little tough for some states, my home state included, where you might not be rising to the top of the highest burden, but we really feel like this is critical to equity to distribute funding to the areas that have the highest prevalence or incidence of these infections. And so do review that data regularly to make sure that it's changing over time and accounted for over time, but do distribute it that way. That helps.
Yeah, and it's great. And there's a comment in there from Ian in regards to syringe exchange, and I kind of want to build on that. Can you comment on how and you did a bit in your presentation, but maybe expand on a little bit more about how syringe exchange programs can reduce rates of hepatitis, and in a state like Idaho, where we've recently had our SEP law repealed. What might we expect? So the people on this webinar who are on the front lines, who are doing prevention education, what might we expect to see in potential trends when an SEP is repealed?
Yeah, great question. And definitely want to make sure that we're continuing to share the evidence on the effectiveness of syringe services programs and other harm reduction programs. So syringe services programs is those, I think it sounds like we have some experts from in the group, really are effective in preventing infectious disease associated with injection drug use by working with community and with people who use drugs to ensure that they have a sterile needle or equipment for every injection use. When we don't have that, we have a risk for transmission if the infection is in the community. And we have, unfortunately, numerous examples of this, whether it's Indiana or West Virginia, Massachusetts, right? And so having these services available is critical. It is not the only lever, but it is critical. The other aspects that I think syringe services programs really play a role in is similar to what a lot of community-based organizations play a role in. It is a place to engage people who need services and for many reasons do not feel comfortable accessing services in other venues. And so this really allows people to engage in an organization that is working to meet their needs. That ranges from transportation to housing to food stability, but also being able to identify that network of providers, healthcare providers, for example, that people feel trusted and that they feel feel comfortable referring people to. And so it really also serves as that network and that hub and that home for people in a community who might not feel that home elsewhere. And so, in communities that may be experiencing challenges with policies, approvals, etc. This is unfortunately not unique. I think we have other opportunities to step up and try to support that delivery of care in that home in other ways. So one of those is to increase HIV, hepatitis C, and other STI screening in other venues. Emergency departments is one that I refer to often, but it might not be as relevant in Idaho. I welcome thoughts on that, but really to be able to put efforts into early detection should infections start to increase and be able to detect those rapidly. Also really thinking about referral networks. How can we best support people in ensuring that if someone is living with an infection, that they are treated and virally suppressed or cured if an option, so that we are limiting the risk of onward transmission within the community, particularly as if there's a lapse in availability of other services. And then there are innovative ways to sort of see if there are other avenues for programs that might be pharmacist syringe sales or making those available free. So I know there's other avenues that places are looking at to see if there are flexibilities in policies and programs that can help address that gap in availability of syringe equipment in particular.
Great. That's again great information to fill in a lot of those gaps that I think we struggle with. And you brought up emergency rooms, and again with the rural and the frontier nature of Idaho, and I encourage other panelists to chime in here. There are sometimes struggles with engaging either the smaller emergency rooms in some testing strategies, and even some of the larger ones. But luckily, there are networks of community health centers across the state, and that sort of safety net is, I think, growing and getting bigger across the state. One more question on STI prevention, and then a couple other questions have come in through the panel. And Nnamdi, whenever you need to give me my 5 minutes, because I could ask Michelle questions all day, you'll need to stop me. So can you comment on some of the newer STI prevention strategies, such as DoxyPEP, and how rural communities may better adopt or implement some of these strategies? And I'm just highlighting, DoxyPEP as an example, but I'm sure there are others. So if you could just give us some thoughts on that.
Yes, definitely. So DoxyPEP is very exciting. I think we're seeing both really positive results from the clinical trials, as well as some newer results. I know it doesn't always feel translatable, but in San Francisco, they're starting to see community level decreases in STIs in their community from the uptake of DoxyPEP. So DoxyPEP is, we're working on our guidelines, but that really is to prescribe doxycycline for use after post-exposure prophylaxis, after a potential exposure. And from the clinical trial data, what we have the strongest evidence on is among men who have sex with men, and transgender women. I need to double check that, apologies. And so we are currently, I think, waiting for some of the evidence to build around heterosexual women, females. So that is sort of work in progress. But the exciting piece out of San Francisco, I think, is that we are seeing decreases in STI rates in the communities that are currently taking DoxyPEP. For more rural areas, I think it still applies, right? Particularly if you have patients or clients, people that you work with that may be have maybe partaking in different behaviors that do increase the risk for STIs. I think the same sort of guidelines would apply regardless of the area, because I think we all know that we're not only in our one city or our one zip code for our whole lives, and then we move, and it might vary. Maybe they're going on vacation, maybe they're going to another area. So really having those conversations to understand what the person's risk might be over time, and really thinking about what their needs might be. I do also want to highlight the congenital syphilis increases and opportunities. I don't think these are new, but really thinking about prenatal screening for syphilis among all people, and thinking about different venues that might be engaging people outside of prenatal care. So one thing that we're seeing is that a large percent of if people are not engaging in prenatal care in a timely manner and are not getting tested, but they are engaging in other places that we could consider doing syphilis screening. And then also thinking about, based on your patient, if repeat screening during pregnancy would also be warranted, and then really working to follow up on timely treatment. There have been some concerns about shortages, but I think we're just about through those, and I think we're hearing fewer concerns about shortages for treatment during for pregnancy. I think I covered that.
Okay, thanks. And Ryan, do you want to chime in with a question?
Hi, Michelle. So two bills that have passed in our legislature. I would love to hear your thoughts about in terms of how it might impact screening and prevention for minors. So one is a bill that changes the ability to receive gender affirming care we've seen in not just Idaho, but passed in multiple states this year. So wondering how that might impact. And then another Senate bill that requires parental consent for minor treatment and how that might impact STIs in particular. Thanks.
Yeah, so I just want to acknowledge, I think these are really challenging when you're trying to really meet the needs of your patients and feel like as a clinician or as a provider that that's not what you're able to do based on different situations. As a state bill, I can't really commentate, but what I can say is that we are looking at these policies and these changes and working to better understand what the outcomes and the effects are on populations so that we can sort of build that evidence around the impact of these. So apologies, I know that's not the most satisfying answer, but we are working to monitor and to really understand what the consequences are.
I think your answer is fair for sure. And I just wanted to say, you know, some of the rationale for repealing the syringe exchange programs was that there wasn't good evidence. Well, we know there is good evidence nationally, but they really want local evidence. And I think it's then important on our group to make sure that we're banding together to provide local evidence of the impact.
Yeah, so thanks for raising that, because I think there are a couple opportunities that we can support. So one is that we are, it's helpful to hear that it was more on the local level evidence, but we are working to do like a refresh on the evidence. We know we hear from others that some of these papers are dated and what's the latest and things have changed. So we are working to sort of update our evidence and our summaries and how we're communicating that. But there's also support that we can provide around monitoring and evaluation and what those outcomes look for your local communities. So if that's something that we can support, please do feel free to reach out.
Thank you. I'll look to the panel for any last questions and attendees as well. Please remember the Q&A. And feel free to type in your questions there, or certainly into the chat thread as well to myself. But with that, hopefully you'll be able to stay on, Michelle, and maybe join us for the few more panel questions towards the end. We might get a few different ones. But again, thank you very much for your presentation. And Nnamdi, I'll turn it back over to you to present our next speakers.
Thank you.
Hey, thank you.
Thank you very much, Michelle and Dave. And before we proceed, I would like to also introduce some other members of the panel, Kevin Brinegar and then Lindsay Haskell from the HIV, STD and Hepatitis section of the Division of Public Health at the Idaho Department of Health and Welfare, who are and sponsors of ICIDP. And also Dr. Ryan Lindsay, who is also a member of the leadership team of ICIDP. So the next speaker is Dr. Sky Blue, who is a board-certified infectious disease physician with an interest in HIV medicine. He earned his bachelor's degree in microbiology and doctor of medicine from the University of Iowa. He completed his internal medicine residency in Phoenix, Arizona, and his infectious disease fellowship at the University of Utah. And he was an assistant professor at the University of Utah School of Medicine, and has been teaching and working at Full Circle Health since 1997, and became the medical director of the HIV clinic in 1998. Dr. Blue also holds the position of medical director for antimicrobial stewardship and infection prevention at St. Luke's Health System. His research interests have been in epidemiology and models of care, and he has been the principal investigator in numerous HIV clinical trials. He's a fellow of the Infectious Diseases Society of America and the Society of Healthcare Epidemiology of America. Dr. Blue was honored as Idaho's Hospital Association's Clinician of the Year and the Ada County Medical Society's Physician of the Year in 2021. He will speak on the challenges of HIV management and control in Idaho and the optimum models of care with this historical perspective. You're welcome, Dr. Blue.
Thank you, Nnamdi, and I'm honored to be asked to present this this perspective for you. And a lot of those things that we just heard about rang true, and we've actually kind of lived through a lot of the changes that have come out. And I think the historical perspective will be interesting because I think it highlights how we got to a lot of the places that we just heard about. So yeah, go ahead, next slide. That's fine. And just to throw out a perspective there, Taylor Swift was born in 1989, and that was just after I saw my first HIV patient in University of Iowa as a medical student. And so I'm going to look at this about where we were kind of before the so-called highly active antiretroviral and where we're going and the different steps along the way. And any kind of nod to the Eras tour is purely incidental and not on purpose. Next slide, please. So this kind of doesn't present as well. I think that pink bug got onto these slides also. But what I want to highlight along each of the eras that we go through is that when we were developing this as we go, we really took what was the function of what we were trying to provide, what tools did we have available, both in our medications and the HIV services, what was out there, and really what did the patient's needs. And so we tried to design how we provided that care based on those areas. And so I'll talk about, OI management, support of the patient, what we were doing and for our antiretroviral therapy at the time, and kind of how our care models came together with that. Next slide, please. So this is just a trip down that memory lane of what was going on during this strategy. AZT was our first reimbursement program that came out in 1987 to try to get medications to individuals. The Ryan White Care Act in 1990, ADAP started around the 1996 when Ryan White was reauthorized. Then, the Title III, now Part C of the Ryan White Care Act came out, but we've seen that the reiterations and the different kind of goals of that program kind of change with the epidemic and the national AIDS strategy, as well as what we heard about care as prevention, even up through the Affordable Care Act. Next slide. Wow. Anybody who's lived through this is going to bring back memories. These are part of the tools that we had for treatment during this time. And I'm going to walk through these separately and kind of talk about where we were and how it actually did change the model of care. Next slide. So Wellness Center, what we call our HIV services clinic, this is kind of our journey from 1997 when we received Ryan White funding for 38 clients. Up to where we are now with our most recent RSR data submission with nearly 900 patients in 2023. And I'm going to talk about some of these things along the road. Next slide. So let's talk about the pre-HAART era. Next slide. So what was going on in the pre-HAART era in Idaho? I moved up here in 1997, so a little bit of this is what I saw as a provider and faculty member at University of Utah. But we had these various monotherapies. We were trying to figure out how to use them. We use them sequentially. There was a huge degree of stigma, throughout the nation, really, and a very high mortality for people infected with HIV. There was very little financial assistance, and a lot of people were completely unfunded. What was going on? Our goals of care were really support of that patient, OI recognition and treatment, a lot of palliative care, and trying to combat that degree of stigma. Infectious diseases got involved a lot in the hospital because these individuals had severe, often multiple OIs at that time. Limited providers in the community, but some were really stepping into this area as well. Health departments in Idaho, the district health departments, were starting in with some coordination. Next slide. So this is kind of what it looks like. A huge amount of support, not much ART, a lot of OI management, and primary care was along the lines of palliative care and that support. Next slide. So we were, FMRI at that time was starting to emerge as a leader in some of the primary care. Dr. Kevin Clifford had a lot of patients he was personally caring for. Other limited providers in the ID physicians in the area would follow individuals, jump in, jump out with some limited ART at the time. Next slide. So then we came into the so-called HAART era, and I'll use this highly active antiretroviral therapy at this stage. In December of 1995, we got approved the hard gel formulation of sequinavir. At that time, it was just one more agent that we had that we tried to say, how is this going to fit in with our monotherapy? But at that time, I think a medical student, early physician, Trip Gulick, actually studied how we could use these in combination instead of sequentially, and really jumped us into this so-called HAART era. From there, we started to get these secondary non-nucleoside treatment options. And we would pair those with our nucleosides to give us this first medication combination that worked. It was huge. Next slide. So these combinations, protease inhibitors coming out, we actually had a medical goal now of viral load monitoring was coming onto the scene. But these medications had high side effects, a lot of interactions. we were learning how to use them. And of course, they were costly, and it was trouble getting those access. So general infectious diseases was starting to come into what we looked at as an HIV specialty care. And this started to pull in people who were general internal medicine, family medicine, primary care providers who had stepped into the breach for our patients with HIV. So they started to form the nidus of an HIV specialty. We started to look at team approach, these medications, working with pharmacists. But we had to work with these community programs for the support of the patient, still to try to combat that stigma. Next slide. Whoa, I'm going to keep you off of these bright pink slides as much as I can. But you can see the expanse of ART here and a little bit of a shrinking of the OI management. Primary care was still a very small part, but a lot of support in this. Next slide. So we started expand services. We got the early Ryan White grant that mentioned in there. So we started to pull in the physicians in the area that were treating these patients. We brought them in. We started to have them each take a day, see patients in our clinic, in the Ryan White clinic, which we called it at the time, to give us access over Monday through Friday. We had pharmacy, we had social work, case management to access ADAP, get the medications to individuals. We had an emergency formulary funded by Ryan White, heavy utilization of industry patients assistance. Because really the point was getting these individuals on the medications. And because that was so important, we started an outreach to areas where in the state where we were starting to see the patients reside. Twin Falls and Pocatello. Next slide. So this is what we saw. We saw the death and the mortality really drop concurrent with the increase in the protease inhibitors, which was a marker for combination therapy. Next slide. We saw the leading cause of death from HIV/AIDS really dropping down to where it was back in the pre-epidemic era, back from 1997. This was huge. Individuals who had sold their life insurance policy, reverse mortgage on their house, now were living because of this combination therapy. Next slide. So then we started to mature in our treatment. We saw the effects. We had multiple classes available. We were starting to treat earlier during this stage. We knew we had effective ART. It didn't help everybody because there were a lot of individuals who were living through that monotherapy age, but we had many, many more options through this time. Our DHHS guidelines, IAS USA were coming out to help. It really was a full-time job to stay on top of what was going on. Treatment recommendations were changing even before the guidelines could come out, based on the clinical trials, based on researchers doing those clinical trials, word of mouth, meetings, and all that. So that nidus of providers we had as a medical director really worked hard to make sure all that information was to the providers. But we were really starting to realize what a medical home is, even before the medical home was a thing. So we would figure out what we were going to treat somebody with. Pharmacists would get involved with interactions. We would get our social work for patient assistance and ADAP. We would get an individual started on that therapy. Nursing would work on adherence. We would follow those viral loads. Resistance testing was really coming on to its own. Phenotype testing was coming on. into this. And the support of those community groups during this time were beginning to integrate into the programs because really to support medical goals here. Next slide. So ART was huge. The opportunistic infection was heavy on prevention, not as much as treatment. But these individuals were living longer. We were getting specific primary care recommendations coming out. We actually started a few little turf battles in the community support areas because they were starting to, say, hey, we were all about this support, and now the emphasis is on the medical model. Next slide. So during this time, the brainchild of Dr. Clay Roscoe, we actually started an HIV primary care fellowship because we found that primary care was is starting to become much more key to this area, although the medical aspect of ART was still huge. And it was actually somewhat easier to teach primary care physicians some of the ART than it was to retrain ID physicians into primary care. We continued our outreach to Twin Falls and Pocatello, and we tried some shared care in this area to try to reach the rural regions of Idaho. It didn't work out real well because ART was shifting so rapidly. Reaching out, mentoring some providers did work. Mentoring some graduates of our primary care fellowship and our family medicine residency worked out. But for example, somebody would have a blip in a viral load. We would change classes in our ART. We wouldn't know what was going on. We wouldn't fix the adherence. It wasn't a team-based approach. We weren't quite getting the outcomes we wanted in that shared care approach in most instances. So we were still trying to get those individuals into HIV specialty care. Next slide. During this time, we had the SMART trial that said the drugs weren't doing it. It was actually the virus. We were starting to lead towards earlier and earlier therapy. Next slide. So this is when retention and care, as mentioned, was really key. We had to get them in, we had to retain them into care. And so we really started to address a lot of these. What was going on in Idaho? The rural, even remote areas, the high degree of stigma. Somebody would not want to get their medication filled in their rural town because that would out them in what was going on. We really tried to wrap around our services for the patient. It was really important to then, get them into a patient-friendly clinic. We used patient panels and a lot of consumer feedback, really started from the Ryan Wright program to make our services friendly. Saturday appointments, all sorts of things to help support them. Mental health, substance abuse, housing was huge. HOPWA was a thing at this time. Transportation, and linkages throughout. Next slide. This is around the time we started to look at this HIV continuum from where you were diagnosed. And we knew that there was individuals out there that weren't even diagnosed. So we had to get them the testing. We had to get them linked to care. We had to keep them in care, give them their antiretrovirals, keep them on their antiretrovirals to get to the place of suppression. Next slide. So we really dove into this barriers to this cascade. And pill burden was a big issue in here. Side effects, adherence. Next slide. Which brought us into this era of single tablet regimens. So ATRIPLA was approved in 2006, a single tablet that gave you complete antiretroviral therapy. It was really a game changer. You know, for individuals who were diagnosed during this period to get on one pill once a day. Wasn't perfect. And we still had individuals who were treading water basically because we couldn't get them undetectable with what we had. During this period of time, we had over 20 clinical trials. We did that because we wanted to get these medications to our patients earlier because that's really what we need. But during this time is when the integrase inhibitors came out. And bam, that was a game changer. We had single tablet regimens, we had integrase inhibitors. So basically during that time, it was a game changer. Next slide. So mentioned a lot of those. We had the National AIDS Strategy. Mother-to-child transmission was effectively zero when we had patients in therapy. Early testing, diagnosis, emphasis on this cascade of care. You know, the primary care was a increasing emphasis. Community programs really pivoted to the testing and entry into this cascade for us. Decreased need for this intensive support, and HIV specialty care was really its heyday during this time, with a decreased emphasis on the ID specialty in there, with HIV specific primary care recommendations. We really had a true medical home here. Next slide. So you can see where primary care was big. ART was very, very important, but it was getting easier and easier. It was getting out of the time when the art of interpretation a genotype and a phenotype was as important, and these single tablet regimens were really easy. Next slide. So the primary care was really, primary care fellowship was really going strong during this time. We brought in an in-house pharmacy. The medical home was huge, but now shared care was actually starting to work again. Good primary care providers on stable ART were starting to, be able to take good care as long as they were linked to some expert care for those times when changes of therapy, side effects, and things came on. ECHO started to come out during this time. Ability to reach the experts in the area. We had done a lot of ECHO-like support even before ECHO came on board in 2011. But shared care was starting to be a little bit more of a thing, and starting to realize more and more of the state that way. Pocatello became a fully funded Ryan White program. We had Chaz Clinic up in northern Idaho, and we were starting to incorporate HIV expertise throughout the state. Next slide. So now where are things going? And I'm not going to talk about present state so much, but we have long-acting antiretrovirals now. Basically, with mental health and substance abuse issues aside, anybody who is diagnosed and in care can effectively be virally suppressed. U equals U. We're really getting at that treatment is prevention. Next slide. So allow me just for a second to jump over the present state and say, where are we going to go in the future? And I'm hypothesizing that cure is going to come, but what we're looking at right now, cure regimens are likely going to be more complicated. Trying to get at the reservoir is not just going to be as simple as another single tablet regimen as what we're seeing. I'm almost anticipating that we might see more emphasis back on there, more like we would see with cancer chemotherapy. Somebody diagnosed with leukemia or lymphoma, you're going to have this period of more intense HIV specialty care to work at getting at a cure. and then back into primary care. OIs are going to be a very small part of this. The support is really going to be ongoing for testing, reducing the stigma to get at what we were talking about, provider bias and things like that as well. So I hopefully took you on a ride through our different models of care from where we were and maybe even speculating on where we're going with all this. We've been through a lot of iterations, but your goals of care, your tools, the community and available resources, and what the patient's needs should really help drive that model of care. And hopefully some of that conceptual give ideas on where we're going to go in the future. And I think that's my last slide. It is. And Nnamdi didn't give me any, big hand waving. So hopefully I'm pretty close to time.
Very much on time, Dr. Blue. Thank you very much. Attendees, please note that Dr. Blue would take questions alongside those of Dr. Stacy Lamers, who is our next speaker. Stacy is a family medicine physician at Full Circle Health, a federally qualified health center and family medicine teaching clinic in Caldwell, Idaho. She also provides HIV primary care to patients in Caldwell and in Twin Falls. She received a Doctor of Osteopathic Medicine with a degree from Des Moines University in Des Moines, Iowa, and completed a family medicine residency at Genesis Regional Medical Center in Grand Blanc, Michigan. After working as a primary care physician in Meridian, Idaho for several years, she had the opportunity to further her interest in public health through the HIV and Infectious Disease Fellowship at Full Circle Health, and remained with the organization to see patients and work with medical students and family medicine residents. She'll be speaking on collaborative approaches and community engagement strategies for addressing HIV, hepatitis C, and STIs in Idaho. Thank you for joining us, Dr. Lamers. You have the floor.
Thank you so much. Can everyone hear and see me okay? Thumbs up.
Yeah.
Great. Well, thank you again. Thank you for Michelle and Dr. Blue, the speakers ahead of me. I have directly benefited from Dr. Blue and Dr. Roscoe's bringing an HIV primary care fellowship. So hopefully I can continue the good work and pay it forward. Can you bring up my first slide? Oh. Thank you very much. Just adjusting my screen. Is the slide up? I saw it for a second and then it disappeared.
Is it this?
Let's see. I only see you talking. Let's see. Let me look at my view standards. Oh, there we go. Perfect. Thank you. So I would like to take us back in time to 1987. Next slide, please. As I was trying to do some research to talk about how we can collaborate with care, I found a very interesting article from the Washington Post that talked about Idaho's response to HIV and AIDS starting in 1985. And I don't bring this up to judge our infectious disease colleagues, public health colleagues at the time, but we bring this up to hopefully understand and learn. As you can imagine, I'm sure in the years to come, 40 years from now, people will look back at how we dealt with COVID and they might have some questions. Next slide, please. So back in the mid-90s, you can see that Idaho started having reporting in 1986. As of 1995, there were about 20. You can see the cumulative totals and the new cases in the state. Next slide, please. And this is to compare with the cases of AIDS in 94 and 95, along with those cumulative totals. Next slide, please. So the force of the article was mostly talking about how Idaho decided we're going to corral the virus. So I thought this is a very Western idea. We have lots of agriculture in our state, so we wanted to get a handle on the virus. So the ways that were thought that we could best handle the virus was by testing and treating. And you would think that that sounds very familiar to us now. Why wouldn't we want to test? At the time, there was anonymous testing, and the legal system changed to require that there was no more anonymous testing, that everyone was going to be identified, and all of that information would be kept confidential, but there would be no more anonymous testing. And there was going to be intensive contact tracing. And today, of course, that sounds like something that we would want to do for most things. But when we think about what was going on at the time, it did cause some concerns for some people. People thought with the non-anonymous testing that they would be branded. Again, another Western concept with the horses. And there was a lot of stigma. There was not a lot of choices for people if they did test positive. They were facing perhaps loss of jobs, discrimination from friends, family, and neighbors. So if you were tested and you tested positive, there was a lot on the line. The article mentioned that some healthcare providers worried because they thought the testing was bringing out a lot of worried well, and they thought that the testing was forcing high-risk groups underground or even leaving the state to get tested because they did not want the stigma of having a positive test. At this time, the article, which I haven't been able to fact check, that article noted that at this time in 1997, only one person was taking AZT date. They also noted that at this time, corrections facilities started more aggressively treating and testing those populations. And there were lots of bills that failed, but they wanted to, things that they were thinking about doing was doing routine testing for all hospitalized patients, et cetera, et cetera. So this article really showed me that we have to be very mindful of what we think are in good intentions so that we don't alienate those that we're trying to help the most. Next slide, please. If we could insert our poll question. So what is CARS? Is it a animated film from 2006? Is it a very fun ride at Disney's California Adventure Park? Or is it an acronym for Community Approaches to Reducing STDs, STIs? There's no wrong answer here, but yes, you all did wonderful. So let's talk about CARS. Next slide, please. So CARS stands for Community Approaches to Reducing STDs and STIs. Next slide, please. So one of the models that I found for CARS looked at ways that we can identify successes in areas to reduce STIs among those who are experiencing disparities, and also as it relates to social determinants of health. Next slide, please. This study looked at locations across the country that had CARS programs, and they evaluated them to look for best practices. Next slide, please. So when they looked at the centers, what they wanted to do was identify, looking at the history of their projects, the stakeholders, the project designs, different partnerships that the centers had, looking at their funding, sustainability, and their own evaluations to come up with what makes a STI prevention program successful. Next slide, please. So let's look at what they found. They looked at 12 findings and called them the 12 critical elements of community engagement. So number one was knowledge and unflagging commitments to authentic community engagement as an approach to reduce local STD disparities. They found that overcoming territoriality, being open to new things, acknowledging that this can take time and be very difficult, and also acknowledging that the people involved are not easily discouraged, i.e. resilience. They found that the commitment to understanding and addressing social determinants of health and how they related to STDs was very important. You're probably all familiar with upstream and downstream factors. Upstreams are things that we think that are out of an individual's control. They're more our structural and systemic findings versus downstream, which are more immediate or individual level factors. They're looked at those that can affect STDs, for example, looking at food insecurity, discrimination, housing, immigration policy, unemployment. Next screen, please. They also mentioned that it's very important for partners to have flexibility, sometimes working after quote unquote normal hours. In this article, they brought up that they wanted to partner with youth and to have a youth voice. And so that meant that they couldn't hold meetings during school hours, that they wanted to meet in early evenings, even weekends. If they had to have partners to have collaborations in places such as bars or clubs, places that typically were outside the walls of normal organizations, they found that to be very helpful. Next slide, please. They found that talented and trusted leadership within the program helped, because you need the right people to establish trust building, to encourage discussion and decision making, but also be catalysts to be able to spur action. Next slide, please. They also found that participation of partners representing diverse sectors was very important, because without inclusion across a spectrum of views and peoples, it's easier to rely on assumptions. And when we have a wide variety of voices at the table, that helps resist stereotypes and biases. They found that collaborative establishment of vision and mission was very important to promote shared understanding and buy-in, and identify and engage new partners. Next slide, please. I found it was very important to share power. I had never thought about this before, but if you're working on a project in your local community, if one person gets the grant, you may not want that one person having the ability to spend the money. You might want to have a separate person getting the grant, and then perhaps an oversight board who is responsible for the the funding. They also made the point that it's very important to share presentations, conferences, meeting, webinars, and papers. So everybody involved should be equally represented in the dissemination of that information. It's also very important to be open to communication, various ways of communicating, and including a diversity of voices. They mentioned be intentional about asking for your feedback, be aware of your body language, and be comfortable with silence. I'm sure we've all been on Zoom calls when we're working as a team. So it's very important not to be looking at your phone, be engaged with your colleagues, and treat everyone with respect. When it comes to making decisions for the group, it is important to decide how decisions will be made. Will there be formal voting, or will you come to conclusions in more of a consensus building way? It was also pointed out that there is shared goals and the importance of embracing and working together through conflict and working on conflict resolution. Always asking for clarification, trying your best to give good explanations, thinking about your own learning, keeping an open mindset, being open to new ideas, and not hesitating to rethinking things you may have come to the table with, but being open to changing your mind. Next slide, please. It's important when you're working with groups to identify strengths, talents, and resources. And by working together, realize that you're developing your own skills by networking, working on critical thinking, problem solving, and leadership. Next slide, please. And to work together to build a shared history of success. Slow and steady usually wins the race. Next slide, please. So since we've reviewed what goes into successful programs, let's look at some programs that we might find in the local area. As our first wonderful speaker alluded to, Michelle, the Let's Stop HIV Together program is here to promote testing, prevention, and treatment, and always to reduce stigma. What I was really struck by was the togetherness part. From my story from the beginning of my talk, when I talked about Idaho's response to HIV in the mid-90s, it was very top down, and it did not include the voices of those we were trying to reach most. And I think you can see over time, we're really trying to work together and collaborate with communities and those that are affected the most, so we are all on the same page. Next slide, please. As you can see, the Let's Stop HIV Together includes testing and treatment, health centers, PrEP, substance abuse, and mental health services. Next slide, please. What I was really struck most about this campaign is the amount of resources that is put into engaging with community partners and how important that is to the campaign. Next slide, please. As you are probably aware, in December, the first part of the Let's Stop HIV Together in Idaho was launched. Next slide, please. On the website, this is a way for people to contact services. Next slide, please. And there is also anonymous testing for HIV too. when I went to the website, this is not available at all states. So I don't know who at Idaho Department of Health and Welfare was able to get Idaho on this. But if you go to this site, if you type in your zip code, you can see that clearly, as long as you live in Idaho, you are able to get free anonymous tests sent to your house. Next slide, please. I would like to take this opportunity to talk about a project that I am involved in with Southwest District Health and how we can apply the CARS criteria in the effort to decrease syphilis. Next slide, please. There is, in February of this year, the Community Advisory Board for Syphilis launched. As you are all well aware, there is increased syphilis in this community, and there are several stakeholders working together to look at what may be contributing to these high syphilis rates. What is the community knowledge about syphilis, and how can we approach testing, treatment, and prevention? Next slide, please. Some of the community partners involved in this work are Southwest District Health, the Idaho Department of Health and Welfare, the local hospital system, St. Alphonsus and St. Luke's, primary care at Full Circle Health, Primary Health, Pathways Recovery, and the Idaho Department of Corrections. Next slide, please. We're trying to consider participant demographics, community awareness, knowledge, how we can address education, looking at access to testing and treatment, barriers to care, and risk behaviors. The first meeting was in February, and we're meeting monthly. We are trying to come up with a questionnaire for those living in this community to help us better address syphilis and how we can further testing, treatment, and education. There are various ways that we can reach people in Idaho. When we talk about hepatitis C, this is a picture of when I was at our Full Circle Health Emerald Clinic. One day I turned around, and in front of our table that would happen to be holding all of our Hep C supplies, you can see that beautiful fibrosed liver. Off to the left are the little cards we give patients to remind them when to come back to their appointments and when they are due for their SVR12. That's a very important lab that we do 12 weeks after the completion of treatment to ensure they have been cured of Hep C. Please forget the product placement in the middle there, but it's also important to show people the size of the tablets they will be asked to take. But when I turned around, I was happy to see the Hep C bus happened to be stopped in front of the clinic. I've noticed lately that there's also naloxone buses as well. Next slide, please. On the back of the bus, you can see the link to the 211 Idaho Care Line that people in the community can get information either by phone or on the internet about different health matters. Next slide, please. Dr. Blue mentioned ECHO. ECHO has been very important for me and other providers in Idaho. ECHO is a program, it's called Project ECHO. It was started by Dr. Sanjeev Arora at the University of New Mexico. He is a GI doctor who specializes in Hep C, and he was struck by the fact that patients waited a long time sometimes to the detriment of their health, to get care. And so to increase other providers' knowledge of Hep C treatment, they started the Project ECHO project for hepatitis C. We also have such a product. We have Project ECHO in Idaho with Hep C, which I have participated in. And it's a great resource. So we don't always have to be experts, but we can get contact with expert opinion. You can bring cases and talk about them in a collaborative way. The patients that you talk about are unidentified, so it's confidential, but you talk about their specific cases and get good advice, and this can increase your own knowledge of treatment. ECHO in Idaho this particular one is run through the University of Idaho, and they also have a host of other ECHOs, including dementia, substance abuse, behavioral health, and is a really good resource for our clinicians. I'm also involved in weekly HIV ECHO through the University of Washington, of which Dave Hatchie, who is moderating today, is also a part of. Next slide, please. As a clinician, I think Michelle, our first speaker, was talking about how important it is for electronic health records to give us a bit of a nudge, because sometimes when we're seeing patients, especially in the primary care realm, there's so much to talk about: high blood pressure, the rash, hey, look at this weird thing on my skin. But using the EHR, this can give us a bit of a nudge. You can see hepatitis screening is right there. I couldn't find one with HIV screening, but every time I see a patient, I always see a list pop up of care gaps that I try to chip away one by one. So this is a really good way for providers to think about testing for HIV, Hep C, and other health concerns. Next slide, please. I have too many people to thank. Next slide, please. Thank you so much. This is the end of my presentation, but I'm certainly eager to hear from my colleagues about their experiences with community STI reduction programs.
Super. Thank you, Stacy. Thank you very much. That was excellent. And Sky as well, if you want to open up your camera, we're just going to open up some Q&A for the two of you. There have been some questions that came through actually during registration. And both of you had more so you, Stacy, had alluded to some of the involvement with corrections and legal aspects with HIV. First question, I was hoping that you might lead us in is what are some challenges that Idaho faces in regards to providing not only HIV care, but prevention of infectious diseases for incarcerated individuals?
Yes, right now, it can be very challenging. I know that most people, upon their introduction to being incarcerated, part of that processing is getting tested. And so sometimes that is where we see new diagnoses of HIV, syphilis, hepatitis specifically. Usually those patients are linked to care. Sometimes when our incarcerated population, say they get transferred to Idaho for some reason, sometimes they come with already have a diagnosis of HIV. And And so it can be very challenging to provide treatment because there's a lot of people falling in and out. If you're housed at a local jail for a few months, sometimes you do not always get access to your medications, and then you get to the state IDOC system. There can be a lapse in care. So it can be very challenging.
And, but if I'm understanding correctly, both treatment of hepatitis C and treatment of HIV is available for
Yes,
persons in prison.
for sure. Yes. So patients involved in IDOC usually get filtered through to Full Circle Health. They can receive telehealth visits and get medications and get their testing done. I should shout out my colleague, Dr. Christopher Link, does most of the Hep C treatment in the IDOC system. So I think that there's good opportunities for our incarcerated population to get tested and a good link to care.
Super. And Skye, I want to ask you this, as you've, I think, seen the evolution of this, not only the evolution of the medications, but also the evolution of Idaho's disclosure law of HIV. And for our attendees in Idaho, there's a law that persons living with HIV need to disclose their status prior to engaging in an activity, sex, or shared needles that may expose another individual. And so I was just hoping you could comment on how you've seen the Idaho's disclosure law impact individuals' willingness to be tested, or some of the negative impacts of that law, or positive impacts. I can't think of many positives, but if you could comment on that, Skye.
Yeah, not throwing me any softballs here. It's been a tough road, and certainly, the whole idea of that law goes into why I had combating stigma on every single era of our care management, and it just adds to that process. And it traces back again to late 1980s, right? When we had a disease that we didn't really understand. We didn't have any effective treatment. And there were some laws that went into place in that time that have not really come off the books, and only, lead to that degree of stigma. So I've seen it kind of go up and down. It certainly is one more aspect where individuals living with HIV feel not part of the community, not really embraced in what they're living with. It has in times affected treatment, especially early on when our therapies were not that good. These days, I have not personally heard about it being a barrier to care, because of our therapies are such life-changing at this stage. I think the message has gotten out that those therapies are important, and to be able to get into that, we have to diagnose you at first. But there was certainly a period of time in there when we were not treating early. We were delaying our therapy to CD4 counts of 200, 350. In that period of time, individuals personally knew they were positive, were not going to get tested because they feared the repercussions of that law. We've seen high-profile incarcerations due to that. We've worked with the IMA and the legislature to try to get that repealed, because I don't think with the other laws that we have on the books, there's really a significant role for that. U equals U. It does not take into account the science that we have right now. So I'm not sure, much else to say on that. And I agree. I'm not, although, it's hard to say that individuals engaging in high risk shared activity should not be upfront in that education. Legislating that has not necessarily led to any benefit, as you had mentioned.
Yeah. There is a question that came in through the Q&A that I want to get to in a second, but I just want to bridge what the two of you are talking about with this undetectable equals untransmittable. So certainly for, I think, a lot of our attendees out there who are sort of in the trenches working with either persons with HIV or screening or providing education, this undetectable equals untransmissible took a while, I think, for clinicians to adopt feeling comfortable, especially people that have been in the care of HIV for a long time. But why don't I throw this one to you, Stacy, to start? How do you share that language of undetectable equals untransmissible with the one-on-one with your clients? What language do you use? How do you empower people? And what have been some of your experiences? And maybe, Skye, you can comment on that as well.
Right. A lot of people, at least, especially when they're first diagnosed, tell me, I don't want to have a relationship ever again. I feel bad about my body. And I tell them, with treatment, you can have a normal life. You can date, you can have kids, you can be like everybody else. U equals U means if you're undetectable, you cannot transmit the virus through sex. Period. You can't, I talk to them about taking your medicine every day. If you're undetectable, you cannot transmit through sex. You can have a normal life and date and like everybody else. We talk about, yes, maybe your partner would choose to take PrEP themselves, but we know the evidence shows that if you are undetectable, you cannot transmit the virus. And sometimes it takes months to years for this to set in for people because they have that stigma that they, feel like they can't be social and have relationships. But I think with our support and understanding, they come to believe that for themselves.
Yeah. And Skye, did you want to add anything to that?
Yeah, it's tough. And I think a lot of individuals who, grew up in Intermountain West have that stigma as well, even though they may now be positive. And so I just, reiterate that, as Dr. Lamers was saying, is that the data is becoming overwhelming that you do not transmit. And it's our viral load testing has gotten so ultra sensitive. We're often seeing a detectable but non-quantifiable level or 100 viral copies. That's not transmittable either. If you are taking your medications, you are undetectable, and really that level is, like we've seen in mother to child transmission, is probably 1,000 to 2,000. It's not these little blips we're seeing here and there. And it's really getting back to getting rid of the stigma. Everybody says HIV is preventable, and it is, and we're working hard on that. So are sunburns, so are cavities, so are parking tickets. But I would really challenge anybody listening on this call who hasn't had one of those, and those are preventable. Nobody, this is not a character flaw. This isn't something that you went out to do. This is not and we have to support our patients to take that to heart. And then you can kind of embrace that U equals U. But as your first question, I always have to put that asterisk in, but you live in Idaho. And so there are laws in this state that are you have to be aware of.
Haven't caught up with the science yet.
Right.
Super. And Michelle, if you want to open up your screen as well, we'll, I think, get some questions that maybe get some broader perspective, open up that lens a little bit, get that aperture open a little bit. But before we do, there was a comment coming in on the Q&A about commenting on treatment possibilities for incarcerated patients on the county level in Idaho. And I can speak briefly here in the eastern side of the state, in southeast and eastern health districts. We have memorandums of agreement with certain county jails that allow for the jails, if they test somebody who's positive, to refer them and link them to care with us. Or some of our staff also monitor some of the jail rosters. But I'd like to get an idea, either Stacy or Skye, of what else you've seen available at the county level, because they don't have a lot of the financial resources, I think, that the State Department of Corrections have, and actually rely on some of the Ryan White services. But what have you seen?
I guess just, go ahead, Dr. Blue.
Go ahead, Skye.
Yeah. Well, I was just going to put in a plug with, as Dr. Lamers was saying, where we are now, we have Dr. Link doing telehealth for hepatitis C. We have, these real strong linkages with our patients in both the county jail and the federal corrections. But those have been hard fought to get to those wins. The education in our corrective health, the presentations and the support with those individuals has been a long time coming. And certainly Ada County Jail, one of the larger jails, gone over and done presentations to their medical staff, creating those linkages, MOUs if you have them. But we take medications to our patients in jail if they need them. We'll connect them with ADAP. We'll get that ball rolling early and often in that support, but it's taken a long time to get those linkages and kind of where we are. When somebody gets out of either jail or prison, we get them in, immediately get them hooked back into care, get them, situated, even if they're going to go out of state, once they're released. So it's been a long time coming in all that, but the jails, really do have to be much more a local linkage and work, while the correction system has had more national emphasis to help them as well.
Stacy, anything additional?
I was just going to mention, at least in the Twin Falls area, those counties, when they have somebody enter their system, they're usually pretty quick to notify us. We were notified, I think, about 2 weeks ago of a patient. I saw them for a telehealth visit yesterday. We're going to be mailing out their meds, or if they're closer, sometimes a case manager will drop them off. But in this person's case, they're getting mailed out today. Hopefully we'll be back on ART in 2 days, and we'll go from there.
Super. And I do want to ask one of our attendees out there to share Danae here in a minute, but maybe Michelle, if you could comment from a more national perspective of maybe best models of care or other things that you've seen at the level of the CDC that have worked in different states.
Absolutely. I think the two models that Skye and Stacy already talked about are great, right? Like those connections between the local health department and the county jail or state health department and state jails and prisons. One thing is that, and I can put the link in the chat in a second, if that'd be helpful, but we also are looking at how do you fund, how do we extend our public health resources to support treatment in those settings. And I think through STI grants, many health departments have 340B eligibility, and those formal relationships with county jails or with state prisons can really extend that collaboration in a more fiscal way. So that might be another model that we're seeing expand. So really extending that through a formal collaboration. If that, I'm not sure if that was being referenced or implied, but that I think is a successful model. And I can also put our quick reference guide for really thinking about the different screening and testing that are recommended at intake, during, and before release. One part that may be particularly relevant for jails is those re-release or those pre-release programs, and really identifying those connections so that there's active handoff before someone is no longer in the jail or prison system, but really identifying those providers so that we're not having gaps in treatment as well. But I'm happy to put those links in if that'd be helpful.
Okay, thank you. And we have Danae Shelburne on, and Danae, we've allowed you to open up. So if you could sort of comment on what you've been working on, what you've seen here.
Yeah, thank you for having me. This has been a great webinar. So we are working in Public Health District 7, and I believe Rachel Muggleston is on as well. And so we're working with Gilead on a pilot project. We have implemented confirmatory testing in the county jail, because previously in a lot of our county jails, they partner with our public health district partners. We provide the test kits for them, but that's just antibody testing. And then that's all we've been able to do in the county jail setting until we implemented this state laboratory. Now we are able to do confirmatory testing. And of course, the next step will, if we know if they have a confirmed infection, how can we provide treatment? And at this point, you're all correct. Funding is scarce. There is no funding basically for treatment in the county jail setting. So we're working with Gilead. They are going to be doing a pilot project in Bonneville, Jefferson, and Madison County Jail. They will be treating 100 patients. And so we're hoping to have a really good template and be able to push this forward and show the state of Idaho some positive, positives of this pilot project, and then hopefully maybe be able to implement that 1115 waiver. I think in Idaho, that's really our next step of how we'll be able to pay for treatment in the county jail setting unless something nationally comes along. And so I need to continue to talk with Dr. Hamzo, the director of Medicaid, to see what that looks like for that 1115 waiver, because it's a great thing. It would be wonderful if we could do that. From what I'm hearing, there's just going to be some concerns from the Medicaid side to be able to enroll that out, as well as the county jail side. How do we enroll folks? Do we have the capacity in the county jail to start enrolling folks in Medicaid, 30 to 90 days prior to release? And it sounds like possibly not, but this is where we can get creative, maybe within my program. Looking at patient navigator, maybe we can support some patient navigators in our county jails, really create a template, and then try to work out, if it works in Bonneville County Jail, maybe we can implement something like this in Bannock County Jail and move out that way. So that's kind of what we're working. It's baby steps. It's challenging, but at least we're making that effort. Thank you.
That's great. Thank you very much, Danae. I think we have time for 2 more questions. I'm going to read one from Marciel. Thank you, Marciel, for joining us today. It's good to see you on. I used to work with Marciel in Twin Falls. I think this is for you, Dr. Lamers. Can HIV screening be added to the care gaps in electronic health records?
It is in our EHR. I can't speak of all EHRs, but I would imagine as long as it should be able to.
And I do know that the community health center that I partner with, it will flag individuals who are eligible, but a lot of providers have what's called flag fatigue, where they see all these alerts and pop-ups and stuff like that, and a lot of times they do get missed. But yeah, I think there are some effective ways out there of reminding providers. All right, the last question, and this one came from one of our attendees that submitted this before, but maybe we can start with Michelle with this one and sort of a broader perspective, and then we'll bring it in and get some thoughts from our other 2 speakers and other panelists if they want to chime in. but what partnerships do you foresee with academic institutions, public health entities, and healthcare organizations in the future? So maybe, Michelle, if you could speak of maybe models out there that you've seen with the CDC and maybe a bigger scale, where you've seen these three entities come together with principles that were laid out by Dr. Lamers of, what can academic institutions bring and partner sort of that three-legged table with public health and healthcare organizations.
Yeah, great question. This is definitely a great space. I think one way that we work with academic partners a lot is really around building the evidence base and thinking about how we work with those partners in different projects to support building that evidence base. So one example is the 1115 waivers. So really thinking about how we're evaluating those, and it's a requirement within those waivers, is to really evaluate those. And so we've actually been working with a few partners to just have them think a little bit about different outcomes that they might not have initially outlined as priorities in their evaluation, but thinking about HIV, hepatitis C, STIs as different outcomes to look at within different waiver programs. That ranges from food assistance 1115 waivers, but also to the correctional pre-release 1115 waivers that many states are working on. So I think that really is that perfect intersection. We're thinking about who sort of has the skill sets, expertise to bring to the table to support some of this evidence building, and then working with those partners that really know what is being implemented when we talk about whether it's waivers or other interventions that are being implemented. Another space that I'm really excited about, and maybe I'll think about how the academics are at the table on this, but one space that I'm really excited about is really that connection between public health and the healthcare systems, and thinking about if a local health department has a DIS or a case manager or peer navigators, are we really working with the healthcare systems that are diagnosing the highest number of people in an area, and how can we really facilitate those close linkages to ensure if you're not able to treat on site, that we're having those connections externally. Florida has really been building this up with some of their Ending the HIV Epidemic initiative funding that I mentioned earlier, really embedding state health department staff in some of their larger hospitals to facilitate linkage to care. So those hospitals are actually also academic settings, so I've looped them in. But I think that's an exciting model that we're looking to expand and build on as well.
Okay. Thanks. And real quick, I guess, before I give the last word to Drs. Lamers and Blue, I'll have a shameless plug on answering this question as well, is that the IDHW believed in this program that's supporting this webinar today to build platforms out of an academic institution where we can look at outcomes and changes in involvement with DIS and other aspects. So this is also although not necessarily a three-legged table, but it's serving as a conduit by which our departments of health and welfare are partnering with the universities to then bring in healthcare providers to share the implementation and everybody's sort of struggles and best practices as well. So we'll start with Stacy and then I guess end with Sky.
Yeah, I've had through the AETC in Idaho, through Idaho State, I've had the opportunity to give talks about PrEP and different facets of HIV, working with Idaho State, especially working with providers, primary providers, where I provide HIV care in the Twin Falls area, as I'm only there one day every 3 weeks. It's a call for me to be those patients living with HIV. I cannot be their primary doctor all the time for all things. So I really rely on the local primary care physicians, nurse practitioners, physicians assistants. So we work together to care with people so using the AETC through Idaho State has allowed me to virtually connect with those colleagues. So we're all kind of on the same page when it comes to our patients living with HIV. So I've really thought that has been a very productive care model.
And Sky, maybe again, you've taken us not maybe on the Eras tour, but maybe a magical mystery tour. So all aboard the naloxone bus. But if you could look into your crystal ball, what would you see is, a good partnership of academia, public health, and healthcare organizations?
Oh boy. Yeah, I was in academics. I was firmly entrenched in academia and haven't been there for over 25 years, but I feel like I've never left. And so if I had to say what I would see on this, and two different things. First, if you're going to look at the academics, why aren't we all part of academics? I would like to see the democratization of clinical research. This is where the patients are. The small amount that get into clinical research in academic medical centers is very small. With AI, EHRs, why can't we take clinical research to where the patients are? Back to my very first slide is form should follow, function should dictate the form. So if we could take academic medical centers, get off their ivory, pillars and out there and just say, we're going to help organize, the ACTG model, really trying to get that back to where the patients are. Collaboration and coordination. We can really get, because clinical research in small little tweaks in your QA plan, how do we reach more people? What are the small little things we can do in the real world that help, that retention and care? What are the barriers to acceptance of Hep C therapy? Why aren't providers doing that? Those are great academic questions. And if we can get those questions to be answered where the patients and the providers are, and certainly that can help the academic individuals publish and support what they're doing, but it also kind of again democratizes where that research can have. So I'd love to see that partnership. As far as the public health and clinical care, I think we're missing harm reduction. We're admitting individuals for substance use disorder, endocarditis, skin abscesses. We're finding those in the hospital, but in the push to get them discharged back out into the community, if we had navigators and care managers to get into harm reduction, and we're not treating the addiction, we're not treating the mental health, we're treating them and treating them, and we're not utilizing our partners in that side, because we could get them out of the hospital easier, prevent their readmissions if we could address those gaps in care. So again, that would be a great research trial for an academic institution to sponsor, looking at a partnership for that. So sorry on my soapbox there.
No, that was great. So I'm going to pass it on to Kristen for some closing remarks. But again, thank you very much to all of you. It has been great. This has been sort of our first go at this. So you guys are all pioneers with us. So with that, again, thank you very much. And I'll turn it over to Kristen for a few final remarks.
Yeah, thank you so much for attending our collaborative meeting today, and a special thanks to our esteemed speakers and our partners at Idaho Department of Health and Welfare. I'm Kristen Vandegreen, Associate Professor of Community and Public Health at Idaho State University, and one of the co-leaders of ICIDP. And I just wanted to say that we've envisioned this collaborative as a culture of shared work and accomplishments in Idaho. Many of us work or live in rural and frontier areas, and we hope that this collaborative is a place to share lived experiences, lessons learned, best practices, and importantly, to celebrate successes together. And it's so heartening for me today to see how many individuals across our state are dedicated to prevention, harm reduction, and care. If you're interested in speaking at our next statewide ICIDP meeting in the fall or have topic requests, please contact Dr. Nnamdi Moiteke, and he was the one who emailed out the link and the information for today. And please complete the brief evaluation form for our webinar today. Thanks so much, everyone.